Hello, everybody. It's Victor with Cardiac Wire, and today we'll be talking to Dr. Eric Goodman and Dr. Darrin Wong from Sharp-Reese Stealy Medical Group in San Diego, California, about their experience with cardiac CT and integrating it into their day-to-day practice. With that introduction, gentlemen, can you please tell us a little bit about yourselves, your practices, and your background in cardiac CT?
Well, Victor, thank you very much for inviting me to talk about cardiac CT. I've been doing cardiac CT since like the mid 2000s, since almost the beginning. I remember even doing cardiac CT, experimenting with it on a four-slice scanner. Certainly, a technical challenge back then, and the technology has dramatically improved to now with much more advanced scanners. But I have been working with cardiac CT for over 20 years, and I have given numerous lectures throughout the years on cardiac CT.
How about you, Dr. Wong?
Yeah, so I'm Dr. Wong, Darrin Wong. I did my training at UCSD, and after medicine residency, I actually had a very unique opportunity to do cardiac imaging prior to cardiology fellowship. I was given the opportunity by Dr. DeMaria, and I was able to learn how to read CTs under Dr. Andy Kahn and Dr. Albert Chow. And then, thankfully, I was able to find a practice at Sharp-Reese where I could still do clinical cardiology and read cardiac CT on a couple days out of the month. And it's been a great opportunity to do that with Dr. Goodman over these last few years.
Well, gentlemen, thank you for the introduction. Can you also tell us, maybe a little bit, having talked about cardiac CT, some insights into how you built a successful cardiac CT practice? What are some of those foundational steps you both recommend?
So we started cardiac CT at Sharp-Reese Stealy, I want to say in 2007, and it was an interesting conversation that we had between cardiology and radiology. In the past, there was not much interaction between the two departments, and I had some experience working with cardiology when I worked at UCSD earlier, and so I proposed that we share this practice, that we jointly read the exams, and we work closely together, and I think that has been the basis of a very successful practice since then.
And Dr. Wong?
Yeah, I joined Reese Stealy in 2020, so long after Dr. Goodman has established a working relationship with cardiology. And again, I entered the imaging fellowship in which the co-reading between cardiology and radiology was already set in place. And so Dr. Goodman was a part of that at UCSD. And I think that culture has continued here at Reese Stealy. And really, I think, again, that relationship and having a collegial relationship between radiology and cardiology is the basis of having a successful practice.
Yeah, so thank you for that background on how you both created a successful practice. Obviously, with success comes a unique generation of image volume. We've heard a little bit about CCTA as a generator of imaging volume. Can you tell us about some of the challenges this brings?
Cardiac CT starts off with a small volume. There's needs to be some education involved to build the practice. And I think, the more success you have, the larger the volumes you will have over time. And I think what we've learned is that if we have high quality imaging with good results, the volumes will keep on increasing to the point that now that we have significant backlogs because of the success that we have had.
Dr. Wong?
Yeah, I think that when people see value in a test and that we are able to deliver results where there are actual clinical items that we can manage or treat, and we're able to convey that well to the ordering providers, then it builds volume. It builds that the tool that we are using is useful to us. And so I think, again, I came in later, but I think Dr. Goodman has created a very robust practice where time and time again we deliver those good results, and people are comfortable with the test that is being given or delivered. And yeah, it's been and has become extremely busy now. And now we're dealing with those rewards, I guess you could say.
I mean, it's very interesting. I mean, Dr. Wong is maybe a different generation than me, and so without a doubt that he was trained with cardiac CT as part of his practice. That he's comfortable with cardiac CT, and most people, I think of, can maybe you could confirm this, that most people that of your generation of trained cardiology is comfortable with cardiac CT. They actually like cardiac CT. Now, but when we started, that was not the case. That was not the case. And so I was working with a generation of cardiologists and other physicians that didn't understand the technology, and they really liked their stress tests, and other types of imaging to manage heart disease. And so things have changed over time, and the data is overwhelming. The power of the test has really been proven over and over again that this is an outstanding test for coronary artery disease.
I think the managing the volume question is interesting, and it really starts from, I think, the beginning. I think managing and having good patient selection, as Dr. Goodman mentioned earlier, and educating the ordering providers of who this exam would be ideal for, helps produce one, good data, and two, the right patients to enter the CT scanner so that we get the answer that is desired, and therefore the volume is minimized and the quality is maintained.
Yeah, I really appreciate those insights into how you're managing volume and kind of your perspective on those volume challenges. With that aside, though, we're seeing some hesitation in adopting cardiac CT, even with the new reimbursement changes. Do you have any recommendations for cardiologists and radiologists who might be hesitating about using cardiac CT in their practice?
So again, it really has to go with patient selection. Okay, especially when you're starting out, is you want to be successful. So you can certainly start with lower to intermediate risk people, which was the main indication for cardiac CT. Things have changed now since the test is becoming much more common. There's improved technology, improved CT scan technology. But in general, you want to start off with the low to intermediate risk patient. And again, you have to make sure that the patient comes with a low heart rate. So you need to make sure that the patient is adequately medicated. And you need to work with a consistent technologist to make sure that the images really are repeated over and over again and are easy to read and give accurate results.
I think, again, patient selection is probably the most important, defining, having a clear-cut guideline, at least within your practice, who should be doing cardiac CT. And again, I think Dr. Goodman is correct in that we are of a newer generation of cardiologists that are more aware, and CT is a common tool used in our practice. But I think, again, having a good working relationship with the radiology department truly can be a barrier for some cardiologists to utilize cardiac CT more, and trusting the protocols that are already set in place, trusting the data, actually from the top down, from the radiologist that is helping read the scans to the technologist that is helping perform the scan, knowing that those building blocks have already been set in place and you can trust what happens. I think that can be a big barrier that the cardiologist has to be able to have that discussion and be comfortable with also knowing the technology behind what goes into that practice before entering and starting to order the scans.
So the technology is very variable out in the community. Not everyone is working with the same technology. So whether you're working with a 64 slice or 4 centimeter detector scanner versus a 16 centimeter or wide detector scanner, or even newer technology, photon counting CT scan, the results are going to be hopefully the same, but takes more effort to get high quality imaging. And so you have to know what you're dealing with to get high quality imaging. And so again, when you have the dual source scanner or a wide detector scanner, the heart rate becomes, less of an issue. But if you're using a older technology, the heart rate is a significant issue. And then there's heart rate, variability. There's many factors that you have to play. So when the images come back and they look a little blurry, you say, well, how do I improve my image quality? These are the factors you have to, repeatedly have a QC process and continued education to make sure that the images really are of repeatedly outstanding quality.
Yeah, I think what Dr. Goodman said is absolutely right. Knowing the limitations of what the tools you are using, the scanner that you're using, knowing how to produce good, or knowing why images are poor, I think also can be a limitation to the cardiologist and somewhat daunting if they are not trained in cardiac CT. And I think it is important to have some education about coronary CT and the things that are required to get good images, I think that is very helpful to the cardiologist once they see the images themselves, and try to review them themselves as to, why is this scan good or why is this scan bad? And I think, again, the technology itself, radiology is not what we're trained for in medicine or in cardiology. And again, it can be a daunting task to know why there is an issue with the actual images themselves.
Gentlemen, I really appreciate both of you giving that background on how it is that we can address some of that cardiac CT hesitation. For those cardiologists and radiologists who really are firmly in the camp of cardiac CT and using it more, since we mentioned earlier the volume increases, do either of you have any tricks of the trade you'd like to share about, like you mentioned earlier, maintaining image quality even though there's higher demand?
If you work with a consistent staff, so I mean, the idea of, say, trying to bring cardiac CT to the emergency department, okay, make it a 24/7 type of test, that's a huge challenge. And then I see over and over again that that's a challenge that is really, really hard to come by, because to find enough technologists that are able to do cardiac CT 24/7, at least at our local hospitals, is not it's not happening. It's not happening. So again, we have limited hours, where during the day where we're doing the CTs with techs that have been well trained, that are familiar with some of the pitfalls, that they know when to contact Dr. Wong or myself to make sure that we can provide high quality imaging. If we come in and, and see people with very large burden of calcium, okay, so if you start bringing an elderly population that have had long-term statin use or something like that, where we know their calcium burden is going to be very, very high, it is unlikely for those exams to be diagnostic. So if we're going to continue to do exams like that over and over again, we're not going to be providing the level of service that we need to provide. So that's just one example where we have to have the whole team really be on the same page. Whether it's the nurses monitoring the heart rate, whether it's the staff checking the calcium score, to make sure that the calcium burden is too high. But we have to have a lot of education to many people in our department for the cardiac CT program to be successful.
Yeah, I think that as volume grows and to maintain quality, we continue to have hands-on work from both Dr. Goodman and myself with the staff, and kind of every day is different, every patient's different, and no one person can be prepped in the same way, I would say, and no one scan is going to be the same between two people. And so we are monitoring the scans on a patient-to-patient basis, making decisions on a patient-to-patient basis. We're at the scanner with the technologist, helping troubleshoot any issues that arise. And I think that truly is needed to maintain quality in which can be a very difficult scan to perform. And so I think that's how we are able to produce, high quality images day in and day out, because we are here, scanner side, helping the staff make sure that patients are, again, selected well and well prepared for the scan.
There is a lot of hesitancy from the technical staff. I mean, they do dozens and dozens of scans a day, and most of these scans are anatomic scans. Whether some of them don't even need a breath hold, whether it's a head CT or an extremity CT. But even the ones that just require a simple breath hold is automated instructions, and it's very, very simple for the technologist to do those scans. Now, there are many other factors in play here that they have to add. They have to check the patient's heart rate. They have to check the variability of the patient's heart rate. They have, and so it just brings up additional anxiety for the technologist, because again, they certainly want the images to come out well. And if we come back and say, oh, these images, are blurry, their response is, well, I mean, I pushed the buttons correctly. I did everything that I was supposed to do. Why is that not the case? And so again, there is this repeated, feedback, again, of continued education, that the checklist is different for cardiac CT than it is for any other CT that I do in my department.
Gentlemen, thank you so much for explaining a little bit some of those tricks of the trade. I know that for the practices out there hearing this, that may be very helpful for them. A little bit more broadly now, before we wrap up, could each of you give us maybe one message that's a takeaway for your colleagues out in the CT space and cardiac imaging in general that you would recommend to those out there who need to improve or are looking for new ways to be better?
So I would certainly invest in technology, okay? Because I certainly think that cardiac CT is here to stay. Okay, this is not a a fad, for lack of a better term. So try to get your administration to buy the best CT that you can buy because it leads to higher quality images more easily. So if you have a wide detector scanner, the breath hold is only 2 seconds compared to a 4 centimeter detector scanner where it's a 10-second breath hold, and it's more chances that there will be heart rate variability and image blurriness. Secondly, I would certainly invest in a 3D lab to have someone be able to help you give additional images to make the cases much easier to read. So those are my two main recommendations.
I think that for success, I think having again a good relation between radiology and cardiology, I think we add two unique aspects to reading cardiac CT and preparing cardiac CT. I think the other, I guess, trick of the trade, I would say, is education and education to the doctors who may be ordering the scan, so that the scans are ordered in the right patients and ordered correctly. And that way you get the high quality data that you desire and the answers that you desire, the clinical question that you want answered correctly. I think that is truly one of the biggest tricks of the trade, is making sure that, the appropriate test is ordered. And so I think education to our primary care doctors and understanding when it is the right test to do is highly helpful. And I think that the last part is, I think we talked about this before, which is just the clinical touch of the exam. We are unique in that we have a cardiologist and a radiologist that are scanner side, and we're actually able to communicate results to the patients in real time. I think that's unique to us. And I think it adds a personal layer to the scan itself, and then it helps also helps us as a practice change and make new clinical decisions based off the data in real time. And I think that's highly helpful for, again, the people that are ordering the test, and we're able to communicate the results not only to the patient, but to the ordering providers almost, again, in real time.
Additionally, I want to add, so as a radiologist, I mean, I'm not a cardiologist. So I've had to work extra hard. I've had to attend CAF conferences. I've had to attend structural heart disease conference to show my images, to be able to explain what I do to what I add as a radiologist to the team. And that has been very helpful in my relationships with Dr. Wong and his coworkers. But I've learned incredible amounts of cardiology. I joke that I am almost a practicing cardiologist. In terms of giving advice to my friends, to other radiologists and about cardiology. I've learned enormous amounts of information over the years that I would not have obtained if I didn't put the extra time in to spend with Dr. Wong, on Wednesdays when we get together. It's been a great relationship.
Well, gentlemen, thank you so much for your time today. It's really rewarding to hear from both of you who are on the front lines of working with cardiac CT, just how important it is to your practice and how much of a difference it can make. Hopefully this conversation leads to changing a few minds out there, and we're really appreciative of your time. I've been Victor. This is Cardiac Wire. Thank you and goodbye.